Claire asked me to talk about advances in research and technology. The bottom line is there is a lot happening. There's a lot happening around the world, but in Australia and in New Zealand, the epicentre of rheumatic fever, rheumatic heart disease research is really at its zenith. And I would point out also that there are emerging research focuses all around the world. And indeed, just 2 weeks ago in Addis Ababa in Ethiopia, there was an amazing meeting convened by the African Union. The African Union, which is the umbrella body for all sub-Saharan African countries, has made a continent-wide commitment to deal with rheumatic fever, rheumatic heart disease, which is, I think, an unparalleled opportunity in the world's hotspot. But they are looking to countries like ours, who have the advantage of access to great resources, can try things out. Obviously, the settings are different, but there are learnings that we can provide to them, and to be honest, there's a lot of learnings they can provide to us. So I'm going to whip through the whole pathogenic pathway, which I hope will have seen sometime today, that takes you from exposure to a group A strep to getting an infection of the throat particularly, potentially of the skin, leading to rheumatic fever, then getting recurrent infections leading to recurrent rheumatic fever and rheumatic heart disease, and then of course the complications. And again, the important message here is that there are bits happening at every bit of this pathway. So we are understanding much more the burden of rheumatic heart disease. This began really with some seminal studies back in the 80s and even before that, when people described this disease that was occurring. And then it really from the 90s onwards, we've started to be more systematic. And indeed, we've more recently, this is work that Sarah Noonan, who's in the audience, undertook to undertake some rheumatic fever surveillance nationally, but we've also started delving into the registers, and the Northern Territory Register is the most sophisticated, the longest lived register, and you can really get a lot of amazing data on how big a problem this disease is, but also about how people are progressing, whether or not there are transitions from mild to moderate to severe, and how long those are taking. And we know that RHDAustralia is convening a national data collection system, which will give us the ability to pull together all the data from all of the jurisdictional registers, look at how we're performing against those key performance indicators. There was a comment, I think, from our New Zealand speaker about the need for economic data. What I can tell you as part of the Canvas initiative, which I'll mention a little bit later, but also I'll talk about more tomorrow, we do have an economic analysis underway. Now that's all about making the economic case for a Group A strep vaccine, but to do that, you have to measure the economic cost of Group A strep diseases, including rheumatic heart disease, and this is in Australia and New Zealand. So those data, or that analysis, is relatively advanced. There's still a lot of other data we don't know, a lot of questions unanswered. How big a deal is this in the urban population? What about immigrant and refugee populations? New South Wales has been a big gap in our understanding, and there's work now to try and fill that gap. And work that Judy Katzenellenbogen, who's in the audience, as part of our CRE is convening, which is how do we pull all this together in a way that uses not just register data, but all the possible data we can to get, if you like, a single source of as close to the truth as we can get of the burden of disease that we can track over time. We've heard about the importance of primordial prevention, of improved housing, of reduced exposure. And we are looking at different ways to deal with this, deal with exposure to Group A strep. But in the meantime, the housing issue is not that easy. There are possibilities, this case management concept of tackling people in their existing environments and talking about how their environments can be altered in some way to reduce exposure to Group A strep. That's a piece of work that is currently being worked up. But we do have a major focus on skin infection, as I think a lot of you know. We don't know that that's definitely going to lead to reduced rheumatic fever. We certainly know it's a good idea regardless. But the concept of building on the work that's happened in the Northern Territory and in the Pacific over the last really couple of decades to try and get a sustainable approach to skin sore control is really, I think, also a major focus of work that's happening across Australia. And of course, in terms of exposure, it's not so much exposure to Group A strep, but infection with Group A strep. Yes, there is work on trying to progress Group A strep vaccines. And that's the Canvas initiative, and come back tomorrow and I'll tell you more. Okay, what happens when you get exposed and you respond? How can we understand more about why it is that some people get rheumatic fever and others don't? We have a study of the genetic risks of rheumatic heart disease. That's an NHMRC-funded study that's been in the Northern Territory that has completed, and we are now undertaking the analysis, and yes, we're finding some interesting genetic hits. And the idea there is to try and elucidate more about the pathogenesis of this disease. Two things I want to highlight for you around that study. One is that we are linked to a global consortium, so there are similar studies happening in the Pacific, in Africa, and in New Zealand. And in the World Congress of Cardiology that's coming up in a couple of months in Mexico, there'll be a big workshop that will try and get us all together, because essentially we want to pool all our results into one big meta-analysis that will hopefully identify what the major host genetic factors are associated with rheumatic heart disease. The second really critical part about that is that the study we've done in Australia had a wonderful component of community engagement, informed consent and governance that really has, I think, made it possible and set guidelines for how this sort of research can be done in the right way in Aboriginal communities. And indeed, a lot of the investigators from Africa and other places are looking to the protocols that we're setting up for that. And I mentioned here immunology of rheumatic fever. You heard the story of Brooklyn, who had nothing that could be given to try and stop her rheumatic fever. Her rheumatic fever went on for months with ongoing valvular damage. Now, that's crazy. It's an immune-mediated disease. We have lots of immune-modulating drugs. Why is there nothing we can give other than penicillin that will make an ounce of difference to whether or not rheumatic heart disease occurs or gets severe? There should be a better way to understand that with modern technology. There's a collaborative project that's been started up between the Walter and Eliza Hall Institute and Menzies, a pilot study that is now moving to the next stage. There's an NHMRC grant that's just gone in to try and better understand the immunology of rheumatic fever with a view to, yes, coming up with a better diagnostic test, but in particular identifying new therapeutics that we could trial to see whether we can stop the progression of cardiac valvular disease. We need to understand sore throat a lot more. As you know, as many of you know, we've had an issue with the fact that in the Aboriginal population we see the highest rates of rheumatic fever in the world, yet at least in the Northern Territory we see very little sore throat and very little Group A strep pharyngitis. And that just doesn't fit with the dogma that it has to follow a strep throat infection. There are clues, and again in Sarah Noonan's prospective study, we found higher rates of prior sore throat. 25% of kids in remote areas with rheumatic fever did recall a sore throat in the previous few weeks. So maybe it's more common than we thought. Still, the vast majority don't have a sore throat, but we know that we now need to investigate whether or not we've been underplaying, if you like, the role of sore throat in remote communities. It's very hard to recommend a major focus on pharyngitis diagnosis and treatment if we're not seeing pharyngitis. But probably the most exciting piece of work has been what's happened in New Zealand. And New Zealand has, over the last few years, had their National Rheumatic Fever Prevention Program, which is particularly built around sore throat diagnosis and treatment. There has been quite a significant focus on skin infection and treatment as well, but the major focus has been on sore throat diagnosis and treatment. The interim evaluation has been published, so you can go online and have a look at it. There's a recent update. It does suggest that there may be an effect. It's early days because I'm reminded of a diagram I saw in the Northern Territory when I returned there in the 2000s. And we also saw a steady reduction over 5 years in the rheumatic fever incidence, and we thought we were winning. And then the next year it just went straight back up again. So we need to see what's going to happen. There may be an effect. What is also important is the cost effectiveness, because this is a very expensive program. Having said that, New Zealand is really, for us, the guinea pig of the world, because they've put themselves out there, made a major investment in rheumatic fever prevention. They've committed to trying to evaluate it as best they can. And over the next few years, we'll get a much better sense as to whether focusing on sore throat diagnosis and treatment is a valuable way to go. I won't focus on diagnosis. I think you've covered most of this today. You've presumably talked about the updated Jones criteria, which I think are rapidly going to re-establish themselves as the international gold standard for diagnosis. And obviously the diagnosis app from RHDAustralia has been a great advance. So let me not dwell on that other than to say we still need a better way and a more accurate way of diagnosing rheumatic fever. Prevention of recurrences. So there is evidence that we are getting there. It's all too slow. And we need to understand better how to get the injections in, again, highlighted by Beau's talk. And so we have a randomised trial of a health systems intervention underway in the Northern Territory that is reaching its conclusion now to try and improve delivery of secondary prophylaxis. And that will, I hope, give some lessons that we can then translate to other settings and take further. But we need to really delve into understanding the perspective of the people living with this disease. We've ignored that far too much, and I'll get onto that a bit later on. And we know that, and this is work that Keith Edwards has really been championing in the Northern Territory, trying to understand much better what the right measure of success in delivery of secondary prophylaxis is, because our current benchmark of 80% of injections is very crude and may not be really the right way to go. So is days at risk the way to go? Are there other measures we need to understand? And yes, for many, many years, people have said, we just need something better than benzathine penicillin. I couldn't agree more. Benzathine penicillin is a great drug. It does work, but we know how hard it is to get those injections in. And so there is a project that we've got underway trying to get a better form of long-acting penicillin. And probably the most important update I can give you on that is that we now have a big pharma interested. And to get a big pharma interested in penicillin is pretty exciting, given that there's no money in it. Early diagnosis, you've presumably heard a bit about echo screening, or you will tomorrow if you haven't today. There's a lot of work we've done around understanding the undiagnosed burden of rheumatic heart disease. There's work on how to improve our diagnosis using more practical tools, such as handheld echocardiography, and this is a piece of work that particularly is being championed out of Africa, but is also being used in other settings as well. And what I can also point out is that the work that we've undertaken in Australia, and we do have an economic analysis that will hopefully soon be published. We are convening a workshop at the Cardiac Society meeting in August in Adelaide, which will be a workshop around echo screening, and then we're going to have a closed workshop with a number of invited people to try and nut out what the right policy recommendations should be in this country. Because some people want to do it, some people don't. People are screening for rheumatic heart disease all over the world, and we need to make a proper, carefully considered recommendation based on not only effectiveness, cost effectiveness, opportunity costs, equity. There's a whole lot of considerations that need to be brought into play, and it's time we did that sort of thing properly. We know that the issue of RHD in pregnancy has really emerged, and thanks to the AMOS study, and I saw Jerry in the audience here somewhere. There you are. This has been a fantastic national study looking at the burden of rheumatic heart disease in pregnancy, and has really identified not only that there is a significant burden, but also gaps in our healthcare delivery to these women that puts them at risk and also compromises their quality of life. And so we're now working up, and this is again, Judy Katzenellenbogen has been working up and the next study, which is called the Mum's Heart Study. Again, it's an NHMRC grant that's gone in to see whether or not we can have a focus on RHD diagnosis in pregnancy, including screening, but also generally improving quality of care as a sentinel way of identifying a chronic disease that has been is a lever to improving overall antenatal care for these women. We know that the Australian guidelines identify priority-based rheumatic heart disease care. We need to dwell down to whether we've got those priority classifications right, and the recommendations for each of those classifications, do we have those right as well? Because the reality is, people ask me, it's great that you got these evidence-based guidelines. Well, there wasn't a lot of evidence that went into those bits. It was very much a consensus of experts around how frequently should people be getting reviewed by a doctor, how often should they get their dental review, how often should they get their echoes. And we now, through the registers in particular, should have the data that we can delve into that. I talked about the need to understand why it is that we have difficulty engaging people with the health system, why it is that we're not getting the injections delivered, why it is that we're having trouble getting adherence to warfarin. And that comes down to really understanding much more what people experience themselves who live with this disease. And there are lots of other unknowns there. And we've talked about the surgery issues, particularly in the last two talks you've heard the reality of surgery for rheumatic heart disease, where we're now needing to really understand better what the outcomes are with the approaches we've been taking, because we've moved over the last 20 years to operating earlier, to trying to do valve repairs. There's this whole question of should we be having centres of surgical excellence? Do we understand the outcomes in kids as much as we understand the outcomes in adults? And again, this is an area that we really need to focus on. And so all that came together, and this is something I'll give you a bit more detail about tomorrow again, with this End Rheumatic Heart Disease Centre for Research Excellence, which is a national consortium of researchers, but researchers very much hooked into the service sector. And it's built around a singular vision. We commit to identify a set of costed, stepwise interventions which are most likely to reduce the incidence of rheumatic fever and the prevalence of rheumatic heart disease for Indigenous Australians to the same level as non-Indigenous, that should be Australians, to eliminate rheumatic heart disease as a public health priority in Australia. And we were very conscious about using the word eliminate, that we've kind of avoided it. And it's about time we didn't avoid it, because if there's a country in the world that we should be able to eliminate this disease, it's this one. There's a long way to go. What we've committed to doing is to trying to develop the plan. The plan's not going to take 5 years to execute. The plan's going to take 5 years to develop. The execution is going to take a generation. But unless we do it strategically, unless we do it in a planned way, we're not going to get there. And this is the programs of work that we have in this End Rheumatic Heart Disease Centre for Research Excellence. You'll be hearing a lot more about it. We're about to kind of launch a communication strategy so that we can give people guidance as to how they can link in with different parts of the program. There are three big pieces of work around understanding the epidemiology and the biology, implementation and translation, and this is that bit that I think really has been the gap, one of our gaps in rheumatic heart disease, which is understanding the lived experience of rheumatic heart disease, and that's a very significant piece of work. So you'll hear lots more about it. I'm very happy for you to engage with me, but there's also a number of other people in the audience who are part of the Centre for Research Excellence, and I'll tell you a little bit more about it tomorrow. Thank you very much.